Hello friends, welcome to PW MedEd. This is the live OBGY recall session of the recently conducted NEET PG entrance exam. I'm your OBGY faculty with PW MedEd, Dr. Shonali Chandra. So I welcome you all to the recall session. So just a bit about the examination. So most of the questions, yes, we had discussed in the sprint series, also in the one shot revision series, and mostly all of them were actually repeat questions, right, in some way or the other, or the topics had been repeated. Even a couple of new questions were fairly easy, I would say, if you would just give a little bit time to think about the question. So all in all, the paper was nice and good. So let's get started regarding the recall question. So good evening, DK. uh, I don't know if you gave the exam or not, or some of you are watching the video were exam goers or not. I hope that all have settled down. So Tanishk, good evening, welcome. Right, so I think we can start with the recall questions. We have 21 questions to discuss. These are recall questions, let me also remind you, so they may not be an exact replica of the questions that were exactly there in the exam, but they will be quite similar. The focus is that they will give you an idea about the pattern of questions being asked. They will give you an idea about the important areas and also the importance of previous year questions. Okay, so Manshud Rana, good evening to you too. So let's get started and have a look at the first question that was asked. So they had asked that there is a 23-year-old primee who's in advanced labor. On examination, the position of the vertex was given at, now there are various discrepancies as to what exactly was the position of vertex. Was it +2 or was it +3 or was it a minus station? I believe it was somewhere in the plus station only. So Pradyumna, good evening, and Achan Khan, good evening to you too. So whatever be the station, let's have a look at the other parts. There was molding, they had given plus plus, cervix was fully dilated, so she was in the second stage of labor. Meconium was also present and the fetal heart rate was decreasing, right? So it was a case of second stage fetal distress, along with, when there is molding plus plus, it means that there is cephalopelvic disproportion, right? So she was already on oxytocin drip as well, right? So contractions were there. And what is the next step in the management? So Rohit is answering correctly, it is an emergency cesarean section. Very good, because see, waiting and watching is not an option, obviously, because fetal distress is happening and she's been in advanced labor for quite some time, most likely. Now the other option is instrumental delivery. Well, instrumental delivery of any kind is not to be done whenever there is evidence of CPD. See, because there was CPD, you see, forceps and vacuum or any form of instrumental delivery is not to be done. So the best answer to choose is emergency cesarean section. Okay, because there was evidence of cephalopelvic disproportion in the form of molding. So I had discussed a similar question in the sprint series also, if you remember, if you were there in that. I talked about a second stage of labor that was been stuck, contractions were there, molding was 3 plus, and capit was there. So I have discussed this already with you people, right, that instrumental delivery is fine when the cervix is fully dilated and station is +2 and beyond. But for instrumental delivery, mind you, there should be no evidence of cephalopelvic disproportion. Only then instrumental delivery. If there is cephalopelvic disproportion, then instrumental delivery should not be attempted, right? So that is the answer to this question. Okay, now let's have a look at the second question. Mithun, very quickly I'll repeat for you. There was a 23-year-old primey, second stage fetal distress was there, evidence of CPD was given because molding was given plus plus, and they had asked you what is the management. So with second stage fetal distress, evidence of CPD, you cannot use instrumental delivery, so answer is emergency cesarean section. Okay, now let's move on to the second question. Which of the following drugs is contraindicated in a pregnant woman who is suffering from asthma? So while you figure out the answer to that question, Meet is saying that molding was 2 plus and no meconium was there. Meet, even if no meconium was given in the question, then also answer would not change, because molding 2 plus evidence of CPD was there. Meconium present, not present would not change the answer. Okay, fine. Now, which of the following drugs is contraindicated in a pregnant woman who is suffering from asthma? So you all know that salbutamol, though anyways, is used for treatment, right? So that is out. Then carboprost, misoprostol, and dinoprostone. So this was a fairly straightforward question, also a repeat question. Carboprost, which is used for PPH management, is a PGF2 alpha analog, and it is a bronchoconstrictor agent also. It causes bronchoconstriction, and that is why carboprost is contraindicated in patients with asthma. So that is the correct answer here. There are as such no medical absolute contraindications to misoprostol, right? But with misoprostol, caution is advised when there is any hepatic or renal dysfunction or any medical comorbidity. So caution is advisable with misoprostol, but as such there is no absolute contraindication. And dinoprostone is PGF2 alpha, and that also has no such contraindication with asthma. Okay, so this was a straightforward question. Now let's move on. Now see how many times, I don't know, they're going to repeat this question. Straightforward, this is the third time in a row that they're repeating this question. What will be the correct score of a 27-year-old woman who is pregnant in her first trimester, and 3 years back she had delivered a full-term twin? So fairly straightforward question. This is a second pregnancy. 3 years back she delivered full-term twins. So she is gravida 2 para 1. Same question I had also discussed with you in the sprint series as well. Same question I had discussed. So this was a repeat question, straightforward. Okay, and study more, answer is not B. Answer is not B. Okay, of course 3 years back she had delivered twins. So one pregnancy 3 years ago, and then she's also pregnant in her first trimester this time now. So she's gravida 2. Okay, and now she's gravida 2. Study more. Okay, now let's have a look at the fourth question they had asked. 53-year-old woman presented to the gynae OPD with a history of lesion in the cervix. Lesion was necrotizing. Investigations is what's found to extend into the parametrium and into the lateral pelvic wall, right? Age is there. Lesion is being described. Findings of the lesion are there. This is cervical cancer most likely, right? So this is a case of cervical cancer, and they had asked the management. So what did I tell you? I discussed with you, gynae cancers a couple of days before the exam, right? So the moment it becomes stage 2B and beyond, it is chemoradiation. It is chemoradiation. So straightforward, and this is also a repeat question, mind you. Recently in the last 5 years, this question was asked. So chemoradiation is the answer. So we had discussed this also, that in early stages surgery is preferable for cervical cancer patient, but once it is stage 2B beyond, once it is a bulky growth on the cervix like stage 1B3 and 2A2, then also answer is chemoradiation is the treatment of choice. So we had discussed this, right? Now, Meet, you are asking, is it suggestive of metastatic cervical cancer as lateral pelvic wall is involved? As lateral pelvic wall is involved, it will be stage 2B. So, of course, it has spread outside the cervix, but there is no distant metastasis that they have described. In this question, they have not described any distant metastasis. Local spread they have described. Stage 2B and beyond is, chemoradiation is the answer. Okay, fine. Now, if you look at the detailed stage-wise management also, then also we had discussed it in detail, right? So please go through. I mean, I will not go into the details of this, but I want to point out that please remember, friends who are going to prepare for INICET next, okay? Cervical cancer is a very, very important topic. Stage-wise management of cervical cancer is increasingly being asked. So if you want to have a quick revision, there is on the PW Meded channel, we discussed all the gynae cancers in 1.5 hours. So you can have a quick revision from there as well. Okay. Now let's have a look at the next question. Not a direct repeat question, but you can answer this question from common sense also. Let's see. A 27-year-old pregnant female came to antenatal checkup during her 7th week of pregnancy. On routine investigation, she had anemia with HB of 9 gram%. What would be the best time to start iron supplementation? So in routine prophylaxis, for all pregnant women that we give, we start in the 2nd trimester, somewhere beyond 16 weeks onwards. But here the catch was that the woman is already anemic. Okay, her hemoglobin is already less than 11 gram%. Okay, so that was the catch. Okay, that she's already anemic. There is moderate anemia. If you classify it, she already had moderate anemia, right? So as such, yes, for prophylactic purposes, we don't really prefer to give oral iron in the 1st trimester for 2 reasons. One, the woman is already having nausea and vomiting, right? So she will not be able to tolerate oral iron because, obviously she will have more propensity or more risk of having gastrointestinal side effects with oral iron therapy. But if required, if there is already anemia, then as such there is no contraindication of starting oral iron treatment. So best time to start oral iron supplementation, I would say there is no harm in giving at 8 to 10 weeks also. So I would say I would choose option A as the answer. What would be the best time to start iron supplementation? But please remember, in 1st trimester, oral iron can be given, but IV iron or parenteral iron, okay, that is contraindicated in 1st trimester. IV iron or any form of parenteral iron is contraindicated in 1st trimester of pregnancy, right? So that is the important point to note here. So here the woman is already anemic, so there is no point waiting to start the treatment. Okay, the diagnosis is already of pathological anemia, right? HB is already less than 11. So there is no harm in starting here itself. 8 to 10 weeks is the best answer to choose among all the options. Okay, Amar. Now, Lakshmi, you're asking, in another question, they had asked in stage 2 cervix, neoadjuvant chemotherapy. Let's come to that question. Good for pointing that out. I have that question with me. Okay, next question. 28-year-old woman with 36 plus 6 days of gestation on examination is in transverse lie. Liker is adequate, placenta is in upper segment, and estimated fetal weight is about 2.8 kg. So everything is normal, okay, except for the lie. Everything is fine except for the transverse lie. Which of the following is the most likely next step in management? I really don't have option number D what it was. If you remember, you can point it out to me. But in this situation, the best answer to choose is external cephalic version. Okay, so all pregnant women who are identified with transverse lie or breach, whether primary, whether multi, doesn't matter, they should always be offered external cephalic version to let's say, give them an opportunity to have a vaginal delivery, right? As long as all the criteria for external cephalic version are met. Okay, so the other option was expectant management. Okay, expectant management. Okay, so if the expectant management is given, then of course the best answer to choose is external cephalic version. So all the criteria for external cephalic version should be met. So what are the criteria? The pregnancy should be beyond 36 weeks of gestation, and I remember very simply, healthy baby and healthy mother, right? So healthy baby and healthy mother would mean that she is more than 36 weeks, right? The liquor is also adequate, the placenta is also in the upper segment, there is no preeclampsia, right, or hypertension, so there are no complications as such, there is no evidence of fetal compromise of any kind, right? And it is a live healthy fetus. It is a live, healthy fetus with no gross congenital anomaly, and the membranes are also present, right? And finally, the last criteria for external cephalic version is that there should be no contraindication to vaginal delivery per se. So, if all the criteria are met, external cephalic version is done. Okay, clear? That's the answer. Now, Meet Patel, I have a comment from you. Mild to moderate anemia, we can deal with dietary modification. What is the need to hurry? Why don't we start from second trimester onwards? I could accept your logic and say start from second trimester onwards. But then but then what is the harm in starting right now? 8 to 10 weeks. She can be prescribed. If there is any gastrointestinal side effects or intolerance, we can decrease the dose, we can change the formulation of oral oral drug treatment. Like for example, you have the ferrous sulfate form of oral iron that leads to more gastrointestinal side effects. I could use the other formulations which are ascorbate, ferrous ascorbate and glycinate, which are less likely to cause gastrointestinal side effects. So treating anemia becomes a priority. We can manage the side effects, right? So I do accept your logic, but you also have to understand, if the options are provided like this, then this was a fairly tricky question. I would say if the options are provided like this, there's absolutely no contraindication, no harm in starting at 8 to 10 weeks. That's why I said best to go for 8 to 10 weeks. And why add permutation combinations when none are given in the question, right? So that would be my explanation for it. Okay, Meet, got it? Now, all right, here's your next question. Which of the following is true regarding neoadjuvant chemotherapy? Or which of the following is, what does neoadjuvant chemotherapy mean? Now, this was, I don't know if the answer was given with the question, if it was specifically asked in reference to cervical cancer or no. But neoadjuvant chemotherapy for any particular cancer means the same thing. Neoadjuvant chemotherapy means chemo given before surgery. As simple as that. That is what is the meaning of neoadjuvant chemotherapy. Okay, chemotherapy given before surgery. Okay, the chemotherapy that is given to increase the efficacy of radiotherapy is given simultaneously with radiotherapy. Then that's called as chemoradiation. Okay, and that's called as chemoradiation. And the chemotherapy that we give to prevent micrometastasis, okay, that we give post-op adjuvant chemotherapy, that we give post-op adjuvant chemotherapy. Okay, simultaneous chemotherapy with radiation, that is chemoradiation, chemo given to increase the efficacy of radiotherapy. And neoadjuvant means chemotherapy given before surgery. The logic of giving a neoadjuvant chemotherapy in any cancer for that matter, not just gynae cancer, any cancer for that matter, is to decrease the tumor burden, to shrink the tumor burden, to shrink the tumor size, so that surgery becomes technically more easier, or let's say less riskier. Okay, got it, right? So post-op adjuvant to prevent micrometastasis, neoadjuvant given before surgery, and I gave you the logic. It is to decrease the tumor burden or to shrink the tumor size so that the cancer can become operable at a later point in time, and chemoradiation is simultaneously given. Okay, now next question. A 25-year-old woman with history of vaginal discharge, dysuria, came to the OPD. Her husband was a truck driver. Now truck drivers are, I don't know, this kind of a history is given, obviously always high risk partner. Okay, could be, I don't like to label people like this personally, but yes, often written in textbooks as to risky sexual history of the male partner. So risk of sexually transmitted infections. On examination, the cervix showed erosion. Okay, so the complaint is that of vaginal discharge. The woman is complaining of vaginal discharge. It could be vaginitis, it could be cervicitis. The fact that they are mentioning cervix showed erosion means that there is cervicitis present. So which of the following is used for our management? We discussed the kits in detail also in our gynae sprint session. And I particularly told you that NACO based kit wala question they have been asking in examination. They first asked the yellow kit, they've also asked the green kit, and now they're asking questions on the gray kit. Okay, so the answer to this is the gray kit. So remember NACO based syndromic approach, when it's just vaginitis, okay, no evidence of cervicitis is there, then it is a green kit. I told you, remember, with green colored discharge of trichomoniasis. When there is cervical discharge, evidence of cervicitis, sexually transmitted infections like chlamydia, gonorrhea are there. So I asked you to remember G for gonorrhea and gray colored kit for that, right? And yellow colored kit I told you to remember with yellow color of pus for PID, for pelvic pain. Okay, so we had discussed this as well. So the answer to this question is gray kit, right? So you see, they ask you questions from the theory that you read only. It is how they frame the question. So they have given you clues regarding that this could be a sexually transmitted infection, okay, risky situation, cervix showed erosion, evidence of cervicitis they are giving you. So they're probably asking you about cervical discharge. So the answer to this question is gray kit. Okay, fine. So remember the kits. Now let's have a look at the next question. A 60. Now there is also a lot of recall bias in this question, and I'm open to you telling me what was there exactly in the question, right? Pradyuman, yeah, right. So truck driver means no regular intercourse. Truck driver probably means the partner may be at risk of having sexual intercourse elsewhere. So probability of multiple sexual partners. It is a saying. It is a saying, guys, that when you sleep with someone, you sleep with all their partners. It's something like that, because maybe your partner is having multiple sexual partners, then you also get exposed to the risk of having infections, isn't it? All right, coming to this question. 16-year-old girl came to the OPD with history of primary amenorrhea, cyclical abdominal pain. So there is history of possibly cryptomenorrhea, hidden menses. And once you think about cryptomenorrhea, there are two possible differential diagnoses to consider: imperforate hymen and transverse vaginal septum. There is a suprapubic bulge also. That could be because of the blood collection inside the uterus or blood collection inside the vagina. On per rectal examination, that was your clue, there was a swelling felt anteriorly through the upper part of the vagina. What is your diagnosis? Through the upper part of vagina, if they are specifically mentioning. First of all, let's rule out what is not the answer at all, right? So not the answer at all is Turner syndrome, and Bartholin abscess is out. I mean, it doesn't present with primary amenorrhea at all, out of the question. So Turner syndrome is not an answer because, again, cyclic abdominal pain. So it's either imperforate or transverse vaginal septum. So we had discussed in great detail. I had taken all the pains to teach you all the permutation combinations of primary amenorrhea. So let's have a look at this image. Similar question I had discussed with the primary amenorrhea of cryptomenorrhea. So if you're doing a per rectal examination, okay, if you are putting your fingers here and doing a per rectal examination, if the collection is along the entire length of the vagina, then the most probable answer is imperforate hymen. And if the collection is in the upper part of the vagina, if they had mentioned that, then your answer would have been a transverse vaginal septum. Okay, so that was the distinguishing feature in the question. All right, so they had not mentioned about the bluish bulge at the introitus. They became tricky this time. Okay, this is the third time in a row that they're asking question on imperforate hymen or transverse vaginal septum, and this time they changed it a bit. Okay, how they changed it? They didn't mention about a bluish bulge at the introitus. Instead, they gave you some other finding. So if there was a swelling felt anteriorly through the upper part, then the most probable answer is transverse vaginal septum. If they had mentioned along the entire length of the vagina, then the answer would have been imperforate hymen. Right? So depending on what they had asked, the answer would change. I believe they had asked upper part of vagina. Now, moving on, let's have a look at the next question. Again, in the sprint series, we had discussed a Bartholin's gland swelling also. We had discussed a Bartholin's gland cyst also. We had discussed an abscess also. So 20-year-old woman with multiple sexual partners came to OPD with pain in the external genitalia. Image was given. It was an image based questions. Maybe not this image, some other image was there, but there was a swelling located on the posterolateral aspect of the vulva. So your diagnosis is a Bartholin's abscess. Abscess becomes a painful condition, right? Abscess will also show other signs of infection. So like we discussed this image, so it was close to this image, a Bartholin's gland swelling. Abscess becomes a painful situation with maybe fever, with maybe some redness, tenderness and warmth, right? And the infective agent is E. coli most commonly, but yes, again with sexually transmitted infections, like mentioned this question, with multiple sexual partners, the risk of sexually transmitted infections like chlamydia and gonorrhea increase, and they could also cause infection of the Bartholin's gland, resulting in Bartholin's abscess. So that was your answer. This was a straightforward image based question. Next question. Again, it was simple. A 23-year-old woman was brought by her mother-in-law to the OPD. If ever you have actually sat in the gynae OPD, I'm 100% sure that you've come across this scenario in Indian OPDs. 23-year-old woman brought by her mother-in-law to the OPD with complaints of not being able to conceive even after 6 months of marriage. What is the next step? She is young age. As such, no high risk factors provided in the question. Just been 6 months after marriage, right? And we evaluate at the end of 1 year, if 1 year of regular unprotected intercourse has occurred, and even then there is difficulty in conceiving, then we start the analysis. So right now it is just reassurance that is required. Earlier evaluation, like let's say evaluation within 6 months of trying, is recommended if the woman's age is, if the age of the woman is more than 35, or if there are obvious risk factors in history. Like for example, obvious risk factors could be that she tells you that I have irregular cycles, I'm a known case of polycystic ovarian disease, right? I'm a known case of some other thyroid disorders, right, which is leading to menstrual cycle abnormality. So obvious risk factors in history. Or let's say on history there is let's say a prior history of ectopic pregnancy, or a prior history of recurrent episodes of pelvic inflammatory disease. If there's obvious risk factors, then one can evaluate early. Otherwise, 1 year after unprotected intercourse. So all that is required right now is reassurance. Now let's have a look at the next question. 45-year-old woman being treated for cervical cancer came to the OPD with her 14-year-old daughter, and she's worried that she will also develop cancer in the future. What's the next step to be done here? When we discussed the cervical cancer and all the gynae cancers, when we discussed, I told you all the genetics about ovarian cancer, I told you all the genetics about endometrial cancer, but I told you there are no such genetic predispositions regarding cervical cancer. So BRCA testing has value in ovarian cancer. It's not required here. Okay, HPV testing. Well, HPV testing is a screening modality for cervical cancer, and that has to begin after the age of 30 years. So she's talking about her daughter, okay, 14-year-old daughter. So HPV testing makes no sense. Study more. HPV testing, she's just 14-year-old. Why HPV testing? HPV testing is a screening test, and HPV based screening tests are done beyond 30 years of age. So HPV testing is also not recommended. Out of the question, cervical biopsy. Out of the question, straightforward incorrect answer. So what are we promoting as a method for preventing cervical cancer? One is screening based early diagnosis and treatment, and the other is HPV vaccine. So HPV vaccine needs to be given. HPV vaccine needs to be given, right? Clear? Okay, HPV vaccine. So most of you have answered this correctly, hopefully, right? So this question, I would say, required a little bit of extra thinking. It was not that straightforward that you would recall it like that, but yes, a little bit of extra thinking was required here. Now let's have a look at the next question. Repeat question. 28-year-old woman came with pain abdomen, missed periods, and UPT positive. Ultrasound showed that she had a tubal ectopic, sac size whatever, 3 by 2 by whatever was given. It was less than 4 centimeter. It was less than 4 centimeter sac size with no cardiac activity, and the HCG levels were given 2600. So HCG levels were less than 5000 milli international units per ml. So what is the next step in the management? So what's the next step in the management? The profile is fitting into medical management of ectopic pregnancy, right? So when we talk about medical management of ectopic pregnancy, it is applicable only as long as the woman is willing and compliant for follow-up. Willing, motivated, and compliant for follow-up. That would be my first criteria. The woman agrees to this kind of a treatment. There is no contraindication to methotrexate therapy, because I know that the agent of choice is methotrexate. So no medical contraindication to methotrexate exists, right? It is an unruptured ectopic. The woman is stable. Okay, woman is stable, unruptured ectopic, right? Sac size is less than 4 centimeter, preferably no cardiac activity, and the serum beta HCG levels at baseline are less than 5000. If all criteria are fulfilled, right, then medical management is done. So in this question, surgery I don't think is the answer, because all criteria were being met. Now those of you who are answering option D, multiple oral methotrexate with leucovorin. When multiple dosage of methotrexate are given, that is in gestational trophoblastic neoplasia. Even in tubal ectopic pregnancy, there is a multi-dose regimen also, but the most commonly used regimen of methotrexate for ectopic pregnancy is the single dose regimen. Okay, so single dose injection methotrexate was the answer. And like you said, Imdadul, one oral methotrexate was there. It's intramuscular methotrexate, IM injection, intramuscular injectable single dose methotrexate, which is the most commonly and preferred regime. Okay, so answer is A here, single dose injection methotrexate. All right. Now, leucovorin with methotrexate is given whenever multi-dose methotrexate is used. So I'm telling you that multi-dose methotrexate for ectopic is one of the regimens, but it is not preferable and it is not the first line regimen. So it's single dose injection methotrexate. So that would be the answer. Now, which of the following conditions, in which of the following condition hysteroscopy is being done routinely? This is logical question, and we had discussed Asherman syndrome also. We had discussed submucosal fibroids. We had discussed submucosal fibroid polyps. So hysteroscopy is done for evaluation of the insides of the uterine cavity. As simple as that. Where are we talking about inside of the uterine cavity? Only in Asherman syndrome. If it's a cervical polyp, if it is a cervical polyp, it will be most likely visible on a per speculum examination, right? So cervical polyp is less likely the best answer to choose. Of course, if you're saying if there's a cervical polyp which is not protruding out, that's another matter. But they're asking you, where is it being done routinely? It is being routinely done for Asherman syndrome, because that is where it is the best modality for making a diagnosis, Asherman syndrome. And study more, not subserosal fibroid, a submucosal fibroid. Subserosal fibroid is here. How can a hysteroscopy diagnose it? Okay, so not a subserosal fibroid. Tubal ligation also is being done laparoscopically, right? So I think option C and D, you should have no doubts at all. Option number A, cervical polyp, most likely will be picked up by local examination itself. So hysteroscopy, we discussed this. Best investigation for hysteroscope for Asherman's is a hysteroscopy. Now let's have a look at the next question. A 23-year-old woman underwent hysteroscopy as a part of diagnostic workup. I'll tell you, this is also a repeat question, not a very recent repeat, but within the last 5 years. Post hysteroscopy, she had 2000 ml fluid deficit. Which of the following is the expected complication? Okay, so what do you think? Yes, fluid deficit is there. So when we do a hysteroscopy, we have to push fluid inside the uterine cavity to distend the fluid cavity. So, fluid instillation into the uterine cavity is done. So whatever fluid goes inside the uterine cavity should also come out. As simple as that. We push fluid in, fluid comes out. Fluid in and fluid out. Okay. So we are always measuring the amount of fluid that we are instilling inside the uterine cavity, and we're always measuring the amount of fluid that is collecting back, right? So that we keep a track of the fluid deficit. So if there is fluid deficit to the extent of 2 liters of fluid, where that all that fluid go? All that fluid can enter into the systemic circulation. And then it can lead to hyponatremia. Right? Hyponatremia. It can lead to electrolyte imbalances. Right? It can also lead to pulmonary edema. Pulmonary edema would be the answer here. Pulmonary edema would be the answer here. Right. Now, Pradyumna, I think why routinely you're asking about the previous question. You're still stuck on the previous question. Being done routinely. Sometimes, being done routinely in the sense that routinely to make a diagnosis. So for Asherman's, ultrasound diagnosis is not very conclusive. You hardly get any finding on ultrasound. And on HSG also, it's just a screening. HSG can miss many times, or HSG is only suggestive. So the only way to actually diagnose Asherman's is hysteroscopy. That's why it is being done routinely here. Right. And of course, Pradyum, you're rightly saying adhesiolysis can be done at the same time. You're right. Okay, so now that you understand this logic here, that the fluid enters the systemic circulation, and the fluid that we are using in hysteroscopy is either a glycine based fluid or it is a normal saline. So all those fluids are isotonic, either isotonic or hypotonic than the plasma. Okay, all those fluids are either isotonic or hypotonic than the plasma. So if that extra amount of fluid goes into the systemic circulation, it is going to cause electrolyte imbalances, and it can also lead to pulmonary edema because of that excess fluid that is reaching the systemic circulation. All right, embolism is a very rare complication. Okay, so embolism is not something that you would expect like that to happen. So Harit, good evening to you too. All right, fine. So the answer is option number D. Now let's have a look at the next question. A 17-year-old came to the OPD with history of acne and mild growth of hair in the beard area. She's a young girl. She's not responding to any antibiotics or isotretinoin. So most probably she's gone to the derma OPD and she's taking treatment for her acne and mild hair growth. Which of the following is the next step in the management? I believe that she's getting the right kind of antibiotics. I don't want to test for antibiotic resistance. Trigger factors less likely. Drugs or food causing acne. See, if there is actually the best thing to do here would not be to look at the other options, but think that, in this age group, in reproductive age group female, PCOS could be a possibility. She could have evidence of hyperandrogenism and raised serum testosterone levels. So best idea would be to check hyperandrogenism. Me too. What is there to discuss about acute tubular necrosis? Acute tubular necrosis is discussed in medicine and surgery, but you want to hear from me? I would expect acute tubular necrosis in the setting of hypovolemia, sudden hypovolemia, which leads to hypoperfusion of the kidneys, which can trigger acute tubular necrosis. In the previous question, they are talking about excess fluid reaching the systemic circulation. They're not talking about hypovolemia at all, isn't it? Fine. Right, Mithu? ATN in brief. All right. Next question. Repeat again. 32-week pregnant woman came for routine checkup with complaints of difficulty in walking and breathing. On examination, her symphyso-fundal height was 41 centimeters. She's 32-week pregnant. The fundal height is more than the period of gestation. Her abdomen was tense but not tender. Fetal parts were not palpable and there was difficulty in auscultating fetal heart rate. Most likely diagnosis. With placental abruption, there would be some evidence of bleeding. There would be some evidence of tenderness would go more in favor of placental abruption, right? So placental abruption is out. There is no history of bleeding. There is no tenderness given. There is no high risk factors for abruption also given. So abruption is not the answer. People are answering correctly. Navjot, study more, answering correctly. Absolutely. Answer is polyhydramnios. So because over distended abdomen, so much so that it is tense, okay, it is feeling tense because the baby may be small inside and it is over distended with amniotic fluid. It becomes difficult to palpate the fetal part, and that's why for similar reasons it becomes difficult to auscultate the fetal heart rate also. The other thing that goes in favor of polyhydramnios is difficulty in walking and breathing, again pointing towards over distended uterus. So polyhydramnios is the best answer. If there is only fetal macrosomia, why would there be difficulty in auscultating the fetal heart rate, or fetal heart rates or fetal parts would not be palpable? So macrosomia is not the answer, and fetal and maternal ascites is also not the answer here, Pradyuman. Not fetal and maternal ascites here. Okay, so I've told you what goes in favor of polyhydramnios. With over distended uterus, these are the clues: difficulty walking, difficulty breathing, over distended uterus, putting pressure on the diaphragm upwards. That's why I'm thinking over distended uterus here, plus fundal height more than the period of gestation. More pointers towards the diagnosis of polyhydramnios. That's why the answer is A and not D, Pradyuman there. Okay. Next question. 28-year-old woman with a history of infertility on treatment with human menopausal gonadotropins. Ultrasound was done. Finding, I don't have it. I don't have a very representative finding. But what was there was, let's say there was an ovary with multiple follicles. Enlarged ovary with multiple follicles. Figure based repeat question as it is. What is the most likely diagnosis? Yes, most likely diagnosis is ovarian hyperstimulation syndrome. Okay, why is it ovarian hyperstimulation syndrome, not anything else? Simply because the history of gonadotropin stimulation of the ovaries is given. Okay, when we do human menopausal gonadotropin stimulation of the ovaries, we stimulate the ovaries to the extent that we get multiple follicles. So at the same time, the ovarian stroma is also stimulated. We get multiple follicles, we get ovarian stroma stimulation, and it synthesizes a factor which is called as vascular endothelial growth factor, which can leak into the maternal systemic circulation and then can lead to complications of endothelial damage. This can leak into the maternal systemic circulation, cause endothelial damage, and can lead to fluid leakage. endothelial damage, and can lead to fluid leakage. So fluid will leak out from the vascular space into the interstitial spaces. Okay, fluid leakage from the systemic circulation, vascular space into the interstitial spaces, and that can lead to symptoms also like that of hypovolemia, hypotension. It can lead to life-threatening complications like that of pulmonary edema as well, and severe hypotension, hypovolemia could also lead to renal failure. So it becomes a potentially life-threatening complication of ovarian hyperstimulation syndrome. So again, answer is OHHS and nothing else. Clue: history of human menopausal gonadotropin stimulation. Next question. A pregnant lady was admitted for pregnancy-induced hypertension for monitoring and bed rest. Okay, in supine position, which of the following is a complication below? What is the complication? You don't even have to read the profile actually to be very precise. In supine position, there is a gravid uterus, right? Gravid uterus is slightly dextrorotated. It can put pressure on the inferior vena cava, and it can lead to supine vena cava syndrome. That is also called as supine hypotension syndrome. That's also called as supine hypotension syndrome. Study more, not abdominal aorta syndrome. Gravid uterus is slightly dextrorotated or tilted towards the right side. That's why it is more likely to put pressure on the inferior vena cava rather than the abdominal aorta. So answer is supine vena cava syndrome, and it is the supine hypotension syndrome to be very precise. Okay, right? So what happens with the supine hypotension syndrome? And we had discussed this also in our sprint series. I had given you a different profile in that question. But the woman was lying on her back and her BP had dropped down. Okay, woman was lying on her back and her BP had dropped down, and I told you it is because of supine hypotension syndrome. Similarly, because of that reason only, because what happens is that when the inferior vena cava gets compressed, when the inferior vena cava will get compressed, there will be peripheral pooling of blood in the lower limbs. So there will be decrease in venous return. Decreased venous return will lead to decreased cardiac output. Decreased cardiac output will lead to decreased BP. Right? And that is the exact reason why pregnant woman, laboring woman, they are preferably asked to lie down in the left lateral position. Left lateral position is the best position to be in pregnancy, right? Because that prevents supine hypotension syndrome. All right, right? So that's the answer there, right? And Anand, you're saying that option was inferior vena cava syndrome. So inferior vena cava syndrome or supine vena cava syndrome, it would mean the same thing. So basically inferior vena cava was getting compressed. So if inferior vena cava syndrome was the option, then that should be the correct answer instead of superior vena cava syndrome. Fine, Anand. So if it was that, then that should be your answer. The logic is this. All right, clear? And also I will give you a third pointer also in case they tend to repeat this question. I'll give you a third pointer also. There can be many profiles around this. A pregnant woman lying down complaining of dizziness, right? A pregnant woman lying down will also have less placental perfusion if she lies down on her backside. That is why it is preferable to be in the left lateral position, right? Because it is in the left lateral position that placental perfusion is also better. Okay, so for the mother's sake also, for the fetus sake also, remember, it is better to be in the left lateral position. Okay, all logic stems from this only, supine hypotension syndrome. Next question. 17-year-old girl presented with primary amenorrhea. On examination, she had no pubic, no axillary hair, well-developed breasts. Height is 155 centimeter, which I would say is fine. Investigations revealed absent uterus, fallopian tube and ovaries. There was bilateral inguinal lump, most likely diagnosis. There are two clues in this question. No pubic hair and bilateral inguinal lump and well-developed breast. All very clear. Why would it be Turner syndrome, Pradyuman? Why would it be Turner syndrome? Turner syndrome patient will have poorly developed breast. Turner syndrome is ovarian cause, right? There is ovarian dysgenesis. Streak ovaries are there. Ovarian dysgenesis is there. So estrogen deficiency is there. estrogen deficiency is there, so breast development will not occur. Okay, and why no pubic hair? No pubic hair, the moment you see no pubic hair, it has got to do with androgens, because pubic hair are androgen dependent hair. No pubic hair means androgen action is not there. No pubic hair simply means that androgen is not acting. Androgen action is not there. As simple as that. So in Turner syndrome, this is not the answer. All right. PCOS can present as primary amenorrhea. PCOS, young early onset PCOS can also present as primary amenorrhea. But then PCOS present with excess androgen action. No, not answer. Hypergonadotropic hypogonadism, no answer. Hypergonadotropic hypogonadism happens with ovarian failure. Okay, and we are not talking about ovarian failure here. Breasts are well developed. So I have ruled out all other options, and I'm saying answer is complete androgen insensitivity syndrome. Right? So complete androgen insensitivity syndrome is the answer here. Right? So whenever there are well developed breasts, okay, we had discussed this. Whenever there are well developed breasts and the information is given to you that the uterus is absent, I told you to look at pubic hair. If your pubic hair are absent and if your pubic hair are present, if your pubic hair are present, most likely diagnosis is Mullerian agenesis. Most likely, okay, and if your pubic hair are absent, most likely diagnosis is androgen insensitivity syndrome. You know what these bilateral inguinal lumps are? These bilateral inguinal lumps are actually undescended testes, right? So in androgen insensitivity syndrome, the gonads are testes and they are secreting testosterone. The gonads are testes, they are secreting testosterone, but this testosterone is not able to act because androgen receptors are absent. Instead, this testosterone gets aromatized to estrogen, and that is why they have well developed breasts. Okay, and these testes are usually undescended testes. And these undescended testes could be inside the pelvis. They could be anywhere along the tract of descent. They could be in the inguinal canal. They could be underneath the labia also. That was another clue. Bilateral inguinal lump, right? So, incomplete androgen insensitivity syndrome, right? Now, Meet, what are you saying that this is, you are saying that there was no breast development. See, I feel that if they had mentioned that there is no breast development, if they are saying no breast development, then they would not have mentioned bilateral inguinal lump. Okay, because they are mentioning bilateral inguinal lump, I would still go in favor of androgen insensitivity syndrome. Chalo, let's say Meet, that there is they are saying that there is poorly developed breasts. Okay, let's assume that you are saying that they had mentioned poorly developed breasts. Let's assume that, and the rest of the question was the same. Even then, I will choose androgen insensitivity syndrome as the answer, because let's say they had bilateral inguinal lump. Meet, is that what you're trying to tell me? That they had mentioned poorly developed breasts along with the same profile? If you are saying that, then also I will not change my answer. Then also I will say complete androgen insensitivity syndrome only. Okay, because bilateral inguinal lump and no pubic hair, 2 pointers towards androgen insensitivity syndrome would be there. Okay, because if there is a young girl with bilateral inguinal lump, okay, let me give you a clear-cut dictum. Okay, ovaries are always inside the pelvis. Okay, it is testes that descend all the way up to the scrotum. If there is a defect in embryonic development which has led to a genetic male turning into a female, okay, now this goes deep. If there is a situation where the genetic male ends up becoming a a phenotypic female, that means the gonads are testes, okay, then think about the possibility of androgen insensitivity syndrome. If there is a bilateral inguinal lump, if there is a gonad that is located either in the inguinal canal or underneath the labia, it is 99.9% a testis. It is almost always a testis. So if they had mentioned a bilateral inguinal lump, I will still say it is complete androgen insensitivity syndrome. There is a possibility that, again, unlikely but possibility, that the androgen levels are so high that they are not allowing the breasts to develop. Excess androgens could also lead to breast atrophy. So I would say that they really went in deep with this question, and maybe that poorly developed breasts or no breast development at all was given to confuse you, but you should have focused on no pubic hair and bilateral inguinal lump. So my answer would still be complete androgen insensitivity syndrome. Are we clear on this? Are we clear on this? Ovaries, whether dysgenetic, whether streak ovaries or whatever, ovaries will never be in the inguinal canal or will never be in the underneath the labia. So in all these three options, there is no possibility that it would be in the ovaries. Okay, so answer would be complete androgen insensitivity syndrome, still I would say. Okay, fine. All right, so we've discussed this question at length. Right, now moving on, let's have a look at the next question. Are we clear on this? Any doubts in this question, ask me straight, otherwise I'm moving to the next question, which is 21st question, last question. So any doubts here? Meet has given me a thumbs up, he agrees with the line of logic we have used to answer this question. Any doubts? Any further doubts? Right, all right, so let's move on to the next question. Which of the following are the disadvantage of laparoscopic hysterectomy? Yes, what do you think? Delayed recovery, post-operative pain, more bleeding, or late identification of electrochemical burn? Now, they are saying hysterectomy, but they could have mentioned cholecystectomy, they could have said appendicectomy, they could have said any surgeries. Okay, what we do inside the abdomen is another matter. All right, the surgical route here is the question. Laparoscopic versus laparotomy route of any abdominal surgery. Okay, so this is a general surgery question, to be very precise. So you know that with laparoscopic surgeries, there are many advantages. There is a small incision site, so the small incision will heal better. There will be less of post-operative pain. There will be less of bleeding from the incision site. Recovery will also be better. Patient can be discharged from the hospital sooner. Patient will be walking around the very next day of the surgery. So all these are advantages of laparoscopic surgeries. That's why laparoscopic surgeries are minimally invasive surgeries. Nahi. So all these are advantages, and the last option is a disadvantage. Late identification of electrochemical burn, because what are we doing in laparoscopic surgeries? We are using the electrosurgical instruments, right? Cautery instruments and all that. So we are ligating and cutting the tissues with the help of electrosurgical instruments, right? So what that does is that always thermal injury, like let's say this is a tissue and there is a probe there is a instrument that is used to clamp this point or this tissue, then there will always be some extent of thermal injury, and thermal injury usually tends to present late. So in laparoscopic surgeries, because we are not inside the abdomen visibly looking at tissues and feeling tissues, then it is possibility that thermal injuries may present much later. So late identification of electrochemical burn, that would be the disadvantage. All right, so this is the correct answer, option number D. Now those of you who are actually going to appear maybe for the upcoming INICET and are going to sit for the examinations next also, I have seen a trend that these questions regarding laparoscopy versus laparotomy surgeries are being asked. Okay, so no, very basic in the sense that you have to understand that nowadays for all sorts of surgery, gynae surgeries, non-gynae surgeries, laparoscopy is becoming very common and preferred route. So basic principles, basic idea about laparoscopy versus laparotomy surgeries in general, you should read up about it. Okay, so this is some area that you need to cover for your upcoming examinations as well, and maybe at a next point in time we could also have a session regarding this as well, right? So with this we finish the recall session, and again, whenever I take a recall, I keep telling you guys that questions, they yes, of course, most of the questions are repeat questions, but they do tend to create, even when they are recall, then even when they're repeating questions, maybe this create some twists and turns. So you have to focus on the, in a question with a clinical profile, you have to look into how many features are fitting into the option, right? And then choose the best possible answer. All right, so sometimes they could make questions tricky in that regard, like we discussed, and we took a long time to discuss this question here, question number 20. So remember the flowcharts that I gave you regarding primary amenorrhea as well. They are very important. All right, and remember the logic. Again, let me emphasize on, when you read about primary amenorrhea and when you just simply mug up the flowchart, it becomes difficult to recall. Then twisted questions you cannot attempt. So before reading about primary amenorrhea, my suggestion would be, please read the embryology of genetic development. Just read the basic concepts also, all right, regarding the development of sex and sexual disorders, because you have this syndrome which is also called as the Swyer syndrome. I just recalled that you have this syndrome which is also called as the Swyer syndrome, 46XY, pure gonadal dysgenesis, which we call as the Swyer syndrome, right? So in this also we have dysgenetic testes. All right. It is a genetic male which becomes a female. Okay, it is a genetic male who turns out to have a female phenotype. But Swyer syndrome patients, they also, because what happens is they do have a uterus present. They do have a uterus present. In fact, adrenal gland androgens in them also lead to pubic hair development as well. So this is another cause of hypergonadotropic hypogonadism, which you could get confused with. But in the question, if they had mentioned absent uterus, then Swyer syndrome would also not be a possibility, right? Because in Swyer syndrome, the uterus is also present, and adrenal gland androgens will lead to pubic hair development. So I'll eliminate any kind of doubts regarding question number 20, right? Now, Pradyuman, your last question is, how much fluid deficit can lead to embolism both in glycine as normal saline medium? Well, 2000 is the limit for 2000 to 2500 ml is the limit for glycine medium. Okay, glycine is isotonic to the plasma, and for saline medium we'll have a lesser threshold, even because saline would become it is not isotonic to plasma. So the complications of pulmonary edema happening, or these fluid deficit happening, they are more with the saline based solutions. Okay. All right, Pradyuman. So let me write it out for you. Let me write it down for you. So in hysterectomy, in hysteroscopy, we have saline media, okay, which we can use for instilling, and we can have glycine media as well. Okay, so glycine medium is isotonic. Sorry, glycine medium is hypotonic, and saline media is isotonic. Okay, so the chances of electrolyte imbalances and pulmonary edema, they are more with glycine based medium and less with saline based medium. So when you ask me the threshold, Pradyuman, threshold would be threshold would be 2000 to 2500 ml for saline, because the probability of having the electrolyte imbalances in pulmonary edema is less, so more fluid deficit can be tolerated. And for glycine medium, it will be slightly on the lesser side, around 1500 ml. Okay, roughly. Okay. All right, Pradyuman. All right. So with this, we finish the recall session now, and if there are no further questions, I will end the session. Thank you so much. Please read up for your upcoming INICET. Again, genital infections, cancers, particularly cervical cancer and amenorrhea, they have come out to be the important topics. Early pregnancy complications, bleeding, abortions, molar, tubal ectopic have come out to be important topics. Okay, fine. All right. Chalo. So let's end the session for today. Thank you so much for watching.